Hey y'all, how's it going? John Asmus here, chiropractic student at National University of Health Sciences, Florida. Today, I'm going to talk to you about cubital tunnel syndrome. So let's start with what it is. It's a compression of the ulnar nerve as it runs through the cubital tunnel of the elbow, which is here on the medial side. This is the funny bone. You ever bang your elbow real hard and then you get a little zinger going down your arm? That is a quick compression of the ulnar nerve. Now, constant compression causes cubital tunnel syndrome. We're talking about it causes medial forearm and hand pain. So going up here, it causes loss of sensation in the fourth and fifth digits, your pinky finger and your ring finger, and motor deficits in flexion of the fourth and fifth digit and the wrist. Also, this is going to lead to decreased grip strength is one of the major components. So looking at the anatomy of the cubital tunnel, start with the medial epicondyle of the humerus right here, and then we have the olecranon of the elbow here. In between those is a little groove. On the bottom of the groove, we have the ulnar collateral ligament, also known as the medial collateral ligament of the elbow. Above that, we have the ulnar nerve. And then above that, we have Osborne's ligament that you can see right here. This is a fascial connection of the flexor carpi ulnaris. So flexor carpi ulnaris, it starts at the hand of the wrist, it travels down, and then it splits. You have two heads. One goes to the olecranon, one goes to the medial epicondyle. In between those two, you have this fascial connection called Osborne's ligament. Now, when flexor carpi ulnaris is tight, it's going to pull on the whole thing, including Osborne's ligament. So it's kind of like a ratchet strap. It's ratcheting down, it's tightening down, compressing on that ulnar nerve. This is what's going to lead to that pain, the loss of sensation, and the motor deficits. So, how would I treat cubital tunnel syndrome? First thing we're going to do, we're going to loosen up that flexor carpi ulnaris. We're going to use manual therapy. I would put the wrist into flexion. I would pin the muscle, and then I would have him go down. Start here, pin it, and have them go down here, and then extend the wrist. That's gonna help loosen it up. By loosening it up, even if it's tight in the more distal portion, it's gonna loosen up the whole muscle. Again, it's like a ratchet strap. The whole muscle's tight. It's not you have one part's tight, one part's loose. No, you're loosening up the whole thing, which is gonna take pressure off that Osborne's ligament, take pressure off of the ulnar nerve. Next, I do therapeutic ultrasound. Ultrasound's great for trigger points, any sort of muscular hypertonicity, including flexor carpi ulnaris. It's great for reducing pain. So I would do it over flexor carpi ulnaris. I would do it over the cubital tunnel itself. I just do it all around the area. Anything that could be pulling and tensioning on that nerve, we want to loosen it up. Next, I would do nerve glides. So nerve glides are great for, sometimes we forget that nerves are physical structures, and we have the nerve itself is getting compressed. So we want to we have things grabbing onto that nerve and holding it in that cubital tunnel. We want to allow it to move more freely through that tunnel. So the way we do that is we put the body in position where it's putting the most tension on that nerve. So we're going to start with the arm out, make an OK sign, put your thumb and your index finger together, and you come around and go into Spider-Man eyes. We're going to do this so nice and slow. As you get in here, you should be feeling it in your fourth and fifth digits. You feel a little tingly, little pins and needle sensations. That's because you're putting tension on the nerve as it goes through that cubital tunnel right there. So I would have the patient do 5 slow reps 3 times a day. Just kind of get that nerve moving through that tunnel. At night, I'm going to have the patient splint. You move all around. Some people do. I roll around, I kick. I'm not a still sleeper. So you don't know where your arms are going, and you could be putting in a maximum flexion position that's putting a lot of tension on that nerve. Now, nerve glides, we're purposely putting tension and we're doing it controlled, but you hold it in that position, that's gonna cause a lot of pain, dysfunction. And so you don't want to be sleeping in a position where you got for 8 hours, you're putting a lot of tension on that nerve. So that's why bracing comes in, and we put it at 45 degrees, and it's puts into the position that has the least amount of pressure on that nerve, and you just hold it there all night. Lastly, we're going to do activity modifications. You want to prevent prolonged elbow extension. So let's say I'm at a computer. I'm here, elbow's at 90 degrees. That's going to put tension on the nerve. So we want to push the computer back so I'm in a position where my arms are nice out, not putting tension on that nerve, and just avoiding any sort of position that you're in a flex position for a long time. So, some research on some of the therapies that I chose. Ultrasound to start. The Acta Neurological Belgica Journal. It's the neurological journal in Belgium. In 2014, they published a study that was a randomized controlled trial with 32 patients. They all had cubital tunnel syndrome. Half of them did ultrasound therapy. Half of them did low-level laser therapy. They were treated 5 times a week for 2 weeks. And they took measurements at the start of treatment, post-treatment, 1 month after treatment, 3 months after treatment. They measured visual analog scale for pain. So pain 1 to 10, where are you at? Grip strength, sensory testing. So they had probes and they could see exactly like whether you can feel, if you're doing a very light touch, can the patient feel that? Or when can they start to feel? Usually you have them close their eyes and you see when can you start to feel, and then but you measure it with a very specific. So you measure the specific amount of pressure that you're putting on and seeing when can they feel that sensation. And then lastly, they did neurological latency testing. So just testing nerve conduction. How fast is that nerve sending signals? Is the impingement in the cubital tunnel is it causing the nerve signaling to be slower? Measuring that, and then patient satisfaction. What they found is that with ultrasound, all of the measurements improved every time they tested it. With laser therapy, they improved the first 3 times. At the 3 month measurement, only grip strength and nerve latency improved. Still pretty good, but to me, ultrasound improved everything every time. Let's go with ultrasound. And here's a study showing the efficacy of bracing and activity modification. This was published in the Journal of Hand Surgery in 2013. And it looked at 24 patients and it had them do activity modification, so staying out of those prolonged flex positions like we talked about, and also splinting at night in that 45 degrees where it has the least amount of pressure on the ulnar nerve. And here's what one of those braces looks like. After 2 years, 21 out of 24 patients avoided surgery. Surgery is an option in cubital tunnel, but to me, we want to avoid that. It's risky. It might not work. You have to go under. It's expensive. That's the last option. That's if we exhaust everything, it's not working. Then we consider that. But 21 out of 24 avoided. That's great. And disability form for the arm, shoulder, and hand. The lower score, the better. They went from an average of 29 to 11. That's showing it's great. It helped them get their ability back with their fingers and hands. The short form is a measurement of dysfunction and pain in patients, and the physical portion of the form showed an increase from 45 to 54. The higher the score, the better. And the mental part showing their stigma around the symptoms that they're feeling, they improved from a 54 to 62. So that's showing they're in a better headspace afterwards, feeling better. And grip strength increased by 3 kilograms on average. That's huge. That's may not sound like a lot, but 3 kilograms of grip strength, that's a lot. And the ulnar nerve provocative testing, you put it in a position where the ulnar nerve is stretched and you see is it creating a lot of pain. Pain resolved in 82% of patients after the bracing and activity modification. So this just shows bracing and activity modification alone could be good treatment options. For me, if you're coming to see me, I'm going to do more. I'm going to stretch those muscles out. I'm going to use ultrasound. I'm going to do everything I can to rapidly decrease your pain and restore function. But bracing activity modification alone is good. So that's why I put that in part of my treatment plan. Lastly, you can use chiropractic adjustments to release a little bit of pressure around the ulnar nerve. But to me, this isn't a joint problem. We're dealing with ligaments and fascia and muscles pulling on the nerve. It's not bones compressing the nerve. So to me, it's not a joint problem. I'm not going to start by treating the joint. I'm going to treat the muscles and the structures that are compressing the nerve. So if everything else is not working, I may try adjusting a patient, but it's not what I would start with personally. And lastly, here are my citations. Thank you so much for listening, and God bless.